This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
How do we manage a case wherein intraoperatively we have detected an extremely loose bag? Let's find out. So this is one such challenging case which I recently encountered. He's an 85-year-old elderly gentleman who has come for cataract surgery. He has pseudoexfoliation and a moderately dilating pupil, mild iridosis and phacodonosis. But it was nothing alarming at the slit lamp. So let's see how things turn out in the surgery. So let me begin the surgery by doing the rhexis. So because the pupil is moderately dilated, about 5.5 millimeter, I thought I would not use any expansion device, and I'm just using a dispersive OD to pressurize the eye and maintain some of the mydriasis. The moment I touch the anticapsule, we can clearly see these radiating folds which are suggestive of zonular weakness, and it looks to be quite profound. But as I start tearing the capsule, it doesn't look so bad. I want to make a slightly bigger rhexis, and at some point I realized that I'm not in great control. I switched to forceps, and with the forceps I have completed the rhexis successfully. At the cost of repetition, hydrodissection is the most important step in eyes with zonular weakness, especially the generalized zonular weakness. And because this is the one which is really going to loosen the cortex and the nucleus stuff from the loose bag. And let's see whether it works well in this case. The nucleus and the cortex appears to be very bulky, and somehow I'm unable to pass the fluid wave across the posterior aspect of the cortex. And as I'm trying to decompress the bag and nudge the nucleus a little bit, I can clearly see that the entire bag is moving along with it. It looks quite ominous. Obviously, the hydrodissection needs to be repeated. I try to repeat it from other quadrants. Again, try to decompress. Well, nothing seems to work. I try to repeat the hydrodissection and it just doesn't work. The cortex and the nucleus material is just so much attached to the bag, it's unwilling to give way. So at this point, I realized that I cannot proceed with phacoing the nucleus with the bag being so loose. At this stage, my mind is thinking of two options: CTR with or without capsule hooks. For me, the first best bet is always going to the CTR. For the simple reason is that I need not make the 4 openings again. So time to insert the CTR. So one trick to negotiate the CTR through a tight bag like this where there's no space is to aspirate just a little bit of cortex from the subcapsular region. Create space in the subcapsular region using a cohesive OVD. This creates some amount of space for the CTR to be threaded in nice and easy. So as was planned, the CTR could be threaded into the bag with relative ease. Now with the CTR in the bag and giving a 360 degrees circumferential support to the capsular bag, I think I'd be in a better position to proceed. But before that, I just want to go ahead and repeat hydrodissection. I repeat it on both the quadrants. And again, I'm trying to decompress the bag and nudge the nucleus a little bit. The same problem continues. The capsular bag is moving along with the movement of the nucleus, suggesting that the CTR alone is not good enough to provide a support for this extensively weak zonules. So the best strategy at this point would have been to introduce the capsular hooks now itself, but my brain was arguing against it and trying to convince me that maybe let us try to do a little bit of phaco and see whether the nucleus loosens up a little bit. So my preferred idea of going in with the capsule hooks was temporarily paused, and I go in with my phaco probe. So I begin by making a couple of trenches centrally, and then I want to rotate the nucleus. Well, the nucleus doesn't budge. So I'm going to use the bimanual technique, wherein I'm going to use the dialer in my left hand as well as the phaco tip to gently nudge and rotate the nucleus. Well, it doesn't seem to work. So at this point I'm thinking, let me chop and take at least one piece out of the bag, and that would create some space which would allow the fluid to creep in and loosen all the adhesions with the capsular bag. So I bury my phaco tip into the substance of the nucleus, and then the chopper goes down. But because the lens is so wobbly, I'm not able to get a very good firm grip, and the chop also is not very convincing, but definitely I can see some cracks and the posterior plate eventually gets separated. So at this point I was momentarily happy. So now I'm trying to take one piece out of the bag. So I go in and try to engage the nuclear fragment and pull it away. The bag also tries to come along with it. So with the second instrument, I retract the capsule. My second instrument is acting as a guard to prevent the anterior capsule from this quadrant, the anterior capsule in the bag to come along with the quadrant. So now with the some of the bag being empty, I'm more hopeful that the further nucleus management could be easier. But as I go in and search for the second part of the same heminucleus, again the bag is threatening to come along with the nucleus and get aspirated into the phacoprobe. Even at this stage, the bag is so floppy that the fragments are sticking onto the capsular fornices and I'm unable to separate it. So I thought mechanically using two Sinskey hooks, can I separate these fragments from the attachment to the capsular bag? So I'm just mechanically trying to maneuver these pieces out of the equator of the capsular bag. But quickly I realized that it's going to cause much more stress on the bag and my hopes wouldn't survive for long if I continued with this technique. So eventually better sense prevailed. I thought the best strategy is to use the capsular hooks to support the capsular bag and then deal with the nucleus. So at this point I realized that we don't have the lens hooks in stock in this particular operation theater, but we had iris hooks and they also do a decent job. So my goal is to use these iris hooks first to stabilize the bag anterior-posteriorly and then deal with the nucleus. So I'm just trying to demonstrate how to create these stab incisions. These incisions are different from the typical side port incisions which we make. These are much more posterior, limbal, and the intracorneal length is very small. So it's predominantly like a stab incision, so that introducing and removing the iris hooks will not be much of an issue. Each one of the hooks is introduced in the pupillary area and then trying to engage the rhexis margin. Now pause the video and write down what can go wrong when you're trying to use these hooks to support the capsular bag, especially in this case because the pupil is slightly mid-dilated and the visualization of the rhexis margin is not great. It would be much more easier if the pupil is very well dilated, but in this situation it's almost like a semi-blind process. Okay, so what can go wrong? Two things can go wrong in this situation. Number one, we may be unsuccessful in engaging the rhexis margin in the first case itself simply because the visualization is not great, the pupil is small, and the rhexis is hidden under the pupillary margin. Second part, the most important one, is there is always a risk of tearing open the anterocapsular margin, especially when you're using these iris hooks. So we need to be very mindful and gentle when you're engaging the capsule with these hooks. So the bottom line message is don't overstretch the hooks, because if you overstretch, these fragile capsules in elderly patients can always give way in spite of having a good rhexis. So that is one thing which we need to be very wary of. So if the rhexis gets torn, then we get into a much more complex situation that we don't want to happen. So the last hook, I'm somehow suspicious that it is not engaged properly. I withdraw and redo it a couple of times, and now I'm convinced that all the four hooks are engaging the rhexis margin and we're good to go. So with the bag now being supported ably by these hooks, I can catch hold of the nucleus and maneuver it out of the fornix of the capsular bag in the more central space and then chop it. Nucleus is divided into smaller fragments and then emulsified. The second part of the heminucleus, which is onto my left hand side, is also eventually held and pulled out of the bag without disturbing the capsular bag and eventually emulsified. The epinucleus is also out. At this point, we're left with some cortex. At this point, I would want to remind my viewers that in eyes with zonular weakness, especially in such a situation, the zonular barrier will be very permissible. So there is always a risk of fluid misdirection developing in this case scenario because the fluid has access to the Berger space across the permissible zonular barrier, and we need to be mindful of that. Although the introduction of the CTR at an earlier stage could have prevented a certain extent, but still the fluid misdirection is a distinct possibility. The cortex is carefully aspirated. At this point, I'm not noticing any positive pressure or thrust, so that I was grateful for. before implanting the lens, I want to remove the hooks simply because my plan is not to implant the lens in the bag. I'm going to implant the multi-piece lens in the sulcus with the haptics being in the sulcus, but the optic pushed back under the excess margin, achieving an optic capture. So this is what I call as an IOL trap technique in these eyes with generalized zonular weakness. And if we have capsule hooks on still, we don't have the space to maneuver the haptic in between the iris and the capsular bag. That's the reason it has to go out. It's going to be still a challenge in this particular case simply because the pupil is small, and I might find it difficult to navigate the haptic above the anterocapsule and below the iris through this compromised visibility because of the smallish pupil. One trick here is always to create some space under the iris by using a cohesive OVD, and I'm going to use my second instrument to just lift up the iris and see that I'm in the right track. See, the distal haptic gets into the sulcus, and then the lens is eventually dialed in so that both the haptics are now in the sulcus. OVD, which is behind the lens, is aspirated out first, followed by the OVD, which is in front. And now is the time to perform the optic capture. With the irrigation handpiece in my left hand, the optic is gently nudged posteriorly so that it gets entrapped into the smallish rhexis which I have. And this is going to provide a long-term stability for this eye as far as the IOL is concerned. So I just want to confirm that the optics have gone behind the rhexis margin. So I'm just trying to retract the iris with my irrigation handpiece and try to ensure that I'm able to see the ovalization of the rhexis margin. And I'm just trying to feel the anterocapsule over the lens. So this ensures that the optic is behind the anterocapsule and both the haptics are in front of it in the sulcus. So this ensures better long-term stability in these eyes with generalized zonular weakness compared to that putting the lens and the CTR in the bag. So we have a CTR in the bag which is going to provide a circumferential stretch and support to the capsular bag, and the multi-piece lens is in the sulcus with the optic being pushed back. Now before closing, I just want to confirm the absence of any vitreous which can prolapse transzonularly. As I introduce the diluted triamcinolone acetate, we can see that it has quickly got access to the Megur space via the transzonular barrier which we have. So I was thankful that I didn't have much of a problem because of fluid misdirection. I just tap the nucleus around, move the eye around, the triamcinolone acetate just gets dispersed and washed out from the anterior root itself. I prefer to constrict the pupil by using about 0.1 ml of pirocarpine. The pupil comes down, the wounds are hydrated, that's it, the case is done. So to summarize, the decision-making error which I made in this case was to prolong the decision to insert the capsular hooks. If it had been introduced immediately after putting in the CTR or after one more attempt of failed hydrodissection, things would have been much more simpler and easier. As I've been telling in many of my previous videos that in such cases, the IOL trap technique is the best way to deal with these eyes. So that was it. Thank you for watching and hope you found this helpful.